Hello, how are you? Welcome to this session where we're going to focus on nursing management of chronic obstructive pulmonary disease, looking at a patient from the nursing angle, from the aspect of admission all the way to discharge. And my name is Winnie Barawa. So this is intentional so that we are able to focus on the nursing side when it comes to how do we manage this client from the admission aspect all the way to discharge, and we shall be observing the rules of assessment, nursing diagnosis, interventions, and the expected outcomes. If you've not listened to the video on chronic obstructive pulmonary disease, kindly watch a video that I will put the link below. But also go ahead and watch the full video in our respiratory diseases playlist. So the agenda of doing it this way is to enable us understand how the nursing process works and how best to approach this disease as a nursing student in case you've been told to manage COPD from admission all the way to discharge. So let's recap and see what we said in the last class in terms of what is COPD. So COPD is a chronic illness for the lower respiratory tract areas, and it involves two illnesses, that is chronic bronchitis and pulmonary emphysema. And in chronic bronchitis, we said this is chronic inflammation of the lower respiratory tracts, which are characterized by hypersecretions of mucus and blockage of the airways. While in emphysema, this is chronic illness that involves destructions or damaging of the airway walls and also coming out with enlarged alveoli. So this being what happens in nursing process or in the management of a patient using nursing process, the first step is required. So in nursing assessment, what are we supposed to do? So under nursing assessment, these are the proposed, or rather we can talk about recommended approach you can do. You can start with the history. So talk about under history, you can observe history of smoking, ask for history of exposure also to respiratory illnesses before, and then check for positive history of family of in terms of respiratory diseases like pneumonia, respiratory illnesses like lung cancers and so on, but also check on the onset of dyspnea. Basically, you want to explore the history of their symptoms. What you talk history of presenting illness. So get the history clearly, smoking history, family history of respiratory illnesses, exposure to smoking also is very important, and the onset of symptoms. This is inclusive of cough, dyspnea, and even the cases of cyanosis and so on. Then when it comes to sputum production, look at the amount of sputum they're producing, the color of the sputum. Is it is it yellow? Is it reddish, indicating presence of blood? How is it? Talk about the consistency of the sputum. Is it mucoid? Is it gelatinous? Is it sticky? Like, what is the consistency so that you can describe your assessment data? So in collation of this assessment data, you basically explore these proposed areas here. Then when it comes to breathing, inspect aspect of use of accessory muscles for respiration, inspect use of abdominal muscles during expirations, then note any increase of the anteroposterior diameter of the chest. Like, is there any changes when it comes to the anteroposterior diameter of the chest? Is it barrel? Is it pigeon chest? Which kind of diameters are we talking about? And talking about diameters, we've also done a beautiful, beautiful video when it comes to respiratory assessment, and it talks about the abnormal shapes of the chest when it comes to assessment. So you can also check it out. I will also link the video link on this video. You can still go watch if you've not watched that, so that you can understand what do we mean about changes in anteroposterior diameters or changes in the respiratory presentations. And the other aspect is auscultating to get data about lung sounds. So you want to auscultate to see if there is decrease in the lung sounds or if there is absence of the breath sounds. But more so, we expect observation of crackles and wheezes and general decrease of the heart sounds. And the other bit is how is the level of dyspnea, that is difficult in breathing, comparison to the patient's baseline assessments, and then aspects of oxygen saturations, both at rest and both during activities. Now, oxygen saturation at these levels of rest and activities are very key because it is going to help us eliminate if our patient could be developing cardiopulmonary complications. After successful collection of nursing assessment data, which is more objective on this side, and you're expected that in your nursing assessment, be good on your history that you've taken from the patient, be exhaustive when it comes to the symptoms and observation of management that have already been done on the client. It's good that also you prioritize the nursing diagnosis based from the most severe diagnosis that you need to prioritize all the way to the least. So here is an example or few prioritized diagnoses that you can use when you're managing chronic obstructive pulmonary disease. And one of it is ineffective airway clearance, which is related to bronchoconstriction, increased mucus production, ineffective cough, possible bronchopulmonary infections. So with the airway clearance, we expect and understand that in the chronic bronchitis, we have aspect of blockage, you have excess mucus production, and this basically leads to blockage of these airways. So you want to focus on airway clearance. Then in the ineffective breathing pattern, talks about ineffective breathing pattern related to the chronic airway limitation due to inflammation. So the chronic obstructive pulmonary disease presents with symptoms of inflammation that is very chronic and tends to constrict the airways. So ineffective breathing pattern becomes one of our priority diagnoses here. Then we have risk for infection, which is related to compromised pulmonary functions with retained secretions and also related to compromised defense mechanisms. So with clients who are COPD diagnosed, most of them present with history of recurrent chronic respiratory infections or history of family chronic infections. Therefore, with this history, then you need to understand that there could be chances that there is immunocompromised status, and so identify this risk in terms of infections and put management or mechanisms to reduce further recurrence of it. The other diagnosis you can have is impaired gaseous exchange related to chronic pulmonary obstructions, abnormalities due to the destruction of the alveoli capillary membranes. So with the impaired gaseous exchange here, we are looking at the walls around the alveoli and the pulmonary and the capillary membranes, capillary networks. This is the area where the gaseous exchange takes place. Now, when we have alveolar walls being destroyed due to emphysema, that literally tells us that when it comes to gaseous exchange at the diffusion space of alveoli and capillaries, then there'll be an impairment there because there'll be no proper control when it comes to how the air is able to diffuse from alveoli or from the blood vessels that we can have. We talk about impaired nutrition, which is less than body requirement related to increased work of breathing, air swallowing, drug effects with resultant wasting of respiratory and skeletal muscles. So our client of COPD, because of the extreme exposure to the symptoms of cough, the symptoms of increase in accessory muscles use, there's chances of fatigue and there's also chances of wasting away. So this client will present with that impaired nutrition, which is less than body requirement. But the other bit is about activity intolerance because client with also COPD has fatigue, they have lack of enough oxygen, and so they have fatigue, general body weaknesses, and so on. So we got symptoms of activity intolerance or diagnosis of activity intolerance related to compromised pulmonary function, resulting in symptoms like shortness of breath and fatigue, or inability to be in more engaging activities like either standing, running. The other thing is about disturbed sleep pattern, which more so is related to hypoxemia and hypercapnia. And lastly, you can talk about ineffective coping related to stress of living with chronic disease and loss of independence. Remember, we mentioned the COPD is a very prolonged disease which can take years, including 1 or 2 years, presenting with symptoms and all the delay in its management. However, you need to remember that in these years of exposure, the client is on anxiety state, worried and not knowing what the outcome could be. So part of this is what can expose clients to depression and they can suffer from ineffective coping abilities, where now we are talking about this ineffective coping related to the stress and the outcome of the disease. So this brings us to which interventions can we do when it comes to the COPD. So it's also advised you work with the nursing diagnosis. So we had talked of nursing diagnosis from airway clearance, breathing patterns, all the way to the coping strategies. So in this case, it's advisable again when you're talking about these interventions, base them basically on the diagnosis. So let's start with the airway clearance. So in the airway clearance, we are told work on improving airway clearance by encouraging cessation of smoking if the client is a non-smoker, maintain a dust-free environment to ensure that there's no triggers or irritants, then have humidification. This is to thin out any gelatinous mucus and to allow it to be released out. Then administer bronchodilators. This is to basically undo the aspect of bronchospasms and constrictions, conduct postural drainage and cough exercises. These are non-approaches that help a client to consolidate any mucus or secretions that are located low into the respiratory tract and to enable them to cough them out. The other aspect is working on improving the breathing patterns, either by encouraging the patient to participate in breathing exercises, which are known for strengthening the diaphragm area and the muscles of expirations, but also it's good to encourage relaxation exercises, which are known for training the muscles and enabling the patient to train the lungs in terms of opening them up in inspiring stages and also during the expiration cycles. The other bit is on infections. Just like we've said, COPD comes with recurrent respiratory infections, and because of this, you want to prevent any further infections that can develop from the patient. So obtain sputum for grind stain and culture sensitivity, administer any prescribed antimicrobial medication for this client to clear the pre-existing infections, and maintain aseptic techniques when we are managing this patient. The other part is improving gaseous exchange. And in improving gaseous exchange, we are saying under gas exchange, we are looking at two sides here. We are looking at the alveolar walls and we are looking at the capillary walls. Where there's an alveolar wall distractions, like in the case of emphysema, then it means we will have low gaseous exchange levels, meaning oxygen will not be having ability to diffuse to the blood system, while carbon dioxide will not be able to diffuse out to the environment. So the best way is to start from reviewing the arterial blood gas levels of our patient by looking at the pressure of oxygen and pressure of carbon dioxide. But also monitor the oxygen saturation and if presence give supplemental oxygen to help us balance the oxygen levels and carbon dioxide in our blood levels. Other management includes improving on nutrition balance. So encourage frequent small meals if the client doesn't have enough appetite or doesn't have good appetite. Then encourage high calorie, high protein meals. In other cases, you can offer frequent liquid nutritional supplements. This is to counteract any side effects such as weight loss in case this client has severe weight loss. So to prevent further malnutrition, then you can give supplements to cater for that. But also remember to monitor weight loss. So you can have a weight loss monitoring chart where on a daily basis you're able to take weights of this client and check how the improvement is coming along. The other bit is on activity tolerance. Improve on the patient activity tolerance by emphasizing importance of graded exercises and physical conditioning programs like having small walks or short walks around the environment. Encourage bicycling or cycling, that is stationary cycling, swimming. However, if you're worried that your client can develop hypoxia while engaging in these activities, it's good you have portable oxygen with you. But train on energy saving techniques of activities. So not everything has to be intense. Just have moderate exercises that are still energy saving and will enable the client to increase their tolerance to engaging activities. And the other bit is improving on sleep patterns. So sleep patterns are very important as they are part of promoting healing of the client. However, when it comes to sleep, you avoid giving the client sedatives. Reason being, sedative medications are known to bring a side effects of respiratory depression. That means it can lower the respiratory rate, it can lower or it can distort the respiratory pattern, and our client can get further complications of hypoxia all the way to issues of hypercapnia and so on. So avoid sedatives basically when it comes to maintaining sleep or enabling the client having a good sleep patterns. Then the other bit is maintaining a very well balanced schedule of activity and rest. And in this case, it will enable the body of the client to adopt well, to understand how to rest and how to activate. But with the sleep patterns is very key when it comes not only to promoting healing, but also it's very key for mental health of this client. Then enhance coping mechanisms. So with coping towards stress and depression of this client or patient, be sensitive to the patient fears and anxiety and strengthen the patient's self-image, strengthen their self-belief, talk about their worries, talk about their fears, talk about what stresses them so that you can enable them to see how they can handle that. Understand that COPD is a long-term disease, so do not assume just because it's a respiratory disease and the client could be under management, you assume the client is okay. No, you need to still encourage coping mechanisms. And lastly, teach the patient on patient education and compliance. And on the health education, there's encouragement to talk about disease progress, disease management, and disease complications. And in all that, you want to ensure that the client is informed, not only to promote client consent, but also help you manage this disease well. And also, even after discharge, you can be assured of management adherence when the client is still at home. And in nursing process, you cannot finish nursing process if you don't have a nursing outcome. So in the nursing diagnosis, in the nursing process management, we have assessment, we have diagnosis, and we have intervention. So you have described the three already. Now this is the last bit. And in the nursing outcomes, we talk about what do you see after you have managed your patient under the nursing process, or what are you expecting to see when this client has been properly managed. So the first thing observable could be cough, where we are saying the cough up secretions are easy, and that is there's decrease in wheezes and crackles. The patient also will be reporting less dyspnea or less difficulty in breathing cases. There'll be no fever, and there's a change in the sputum. So the temperatures will be lowering and the sputum production will also be lowering. Then the ABG levels will be improved. That is, you will see good partial pressure of oxygen and normal levels of pressure of carbon dioxide. And on the SpO2s, that is pulse oximeters, you will see improved in terms of oxygen flow. And the other bit is tolerance in frequency, tolerance in terms of meals. So find the patient is eating well, there's good diet, there's good appetite, and the weight is becoming stable. In terms of activity tolerance, the client can report cases of longer walking distances, there's low tiring aspect, fatigue is limited or there's not fatigue, and the sleeping pattern will also be stable with our client able to withstand 4 to 6 hours of sleep. However, this client will also be not needing oxygen in any of these activities. But there's also demonstration of good, effective coping mechanisms like ability to express feelings, ability to express need for support. And these are good outcomes because it shows that the management done on the COPD client is positive and the patient is showing good indicators that there's a good improvement. And that's all, guys, when it comes to the nursing process in regards to COPD. And if this was really helpful to you, remember to subscribe if not yet done that. Please share with your parts of your people that you are studying with or you are learning together with. Comment, share, and also like this video. Thank you so much and see you in our next class.